Swayam Prabha. Digital India. Educated India.
Hello everybody, welcome to the course on precision oncology. We are covering the topic tumor microenvironment. In the last lecture, we saw what is tumor microenvironment, what are the components of tumor microenvironment, how tumor microenvironment interacts with the tumor, and how the tumor progression is dependent upon the tumor microenvironment. Today, we are going to see how to target the tumor microenvironment. Now, tumor microenvironment we saw is comprising of a lot of different types of cells. So today we will see how to target the ECM, the extracellular matrix, hypoxia and acidosis, neovascularization, immune system, chronic inflammation, activation of anti-tumoral activity, exosomes, cancer-associated fibroblasts, combined therapies which are acting very effectively in targeting the tumor microenvironment, and nanomedicines. Along with this, we will also look at certain models to study the tumor microenvironment. As we all know, cancer development is highly associated with physiological state of tumor microenvironment. We have genetic alterations which happen in the tumor cells which result in hyperplasia and leading to uncontrolled growth and resistance to apoptosis. Actually, there is a metabolic shift towards anaerobic glycolysis, which we call as the Warburg effect. In Warburg effect is otherwise called as the aerobic glycolysis, where the cancer cells are transforming significant amounts of glucose into lactate and ATPs. So here, when cancer cells undergo glycolysis, they produce a lot of lactate irrespective of whether oxygen is present or not to meet their energetic demands. This Warburg effect gives the cancer cells advantages for growth as well as for survival. Now, there are a lot of cascading effects which happen because of this Warburg effect. If you look at the cancer metabolism in the normal cells undergo glycolysis and they undergo the oxidative phosphorylation in the mitochondria. But maybe in cancer cells, the mitochondria are injured or they are faulty in mechanism. The cancer cells are using an alternate mechanism, that is, they kind of have an increased mechanism to undergo glycolysis, which happens in the cytosol and not in the mitochondria, and they convert the pyruvate into lactate. So, therefore, the increased glycolysis in cancer cells leads to excess production of lactate. There are a lot of cascading events which happen because of the Warburg effect in the cancer cells. Now, these events, that is because of an excess production of lactate, there is a region of hypoxia which is formed, and also an increased acidic environment which is formed. That is, these events, the Warburg effect, creates hypoxia, oxidative stress, and acidosis within the tumor microenvironment, and which trigger an adjustment within the extracellular matrix. So there is a response from the neighboring stromal cells, that is fibroblasts and immune cells and the lymphocytes and macrophages, and therefore a lot of different kinds of arrangements which happen within the tumor microenvironment, which pushes the environment towards neovascularization, angiogenesis, and metastasis. Now, the picture here shows the different components of a tumor microenvironment. Now, the cell, the cartoon A, that is, it is a tumor microenvironment of a late stage solid tumor. So you can see that it is highly heterogeneous and complex. You have several different types of cells which are present in this tumor microenvironment. You have the normal cells and the tumor cells, and the atmosphere is highly heterogeneous, and it leads to the formation of desmoplasia. Now, coming to the component B, that is the cartoon B, within the tumor microenvironment, you also have exosomes. These exosomes play important role in paracrine and autocrine communication between the tumor microenvironment cells, and they are preponderant in modulation and in development of tumor. The exosomes are also involved in transformation of the normal cells adjacent to the tumor microenvironment into tumor cells. So you may have different types of exosomes, like you may have the exosomes which are from the derived from the immune cells, derived from the stromal cells. So from the normal cells, every single type of cells which are present in the ECM will be forming different kinds of exosomes, and all these exosomes have extensive communication in the tumor microenvironment. Now coming to the cartoon C. Now this C here picture shows a rapid growth of the tumor cells which results in hypoxic regions due to lack of nutrients. When the tumor cells rapidly proliferate, they need blood supply. So when the blood supply is limiting due to an excess proliferation, it leads to the area of hypoxia, that is less oxygen, and the lack of nutrients within the tumor, which will again cause Warburg effect. So there is a metabolic shift to the anaerobic glycolytic pathway, which leads to acidification of the tumor microenvironment. As we saw, due to an excess of lactate production, the acidification increases within the tumor. Now, coming to the component D, the cartoon D here shows the vascularization of the tumor microenvironment. When there is rapid growth of tumor cells, this will induce angiogenesis, and it actually leads to formation of chaotic branching structures within the tumor cells. The stromal cells, which include the cancer associated fibroblasts and the mesenchymal stromal cells and cells from the immune system, which belong to both lymphoid as well as myeloid lineage, they're all important players in this tumor microenvironment. Now let us see how we can target the TME, the tumor microenvironment. As we all know, chemotherapy is the leading cancer therapy worldwide, and it is often combined with other modalities of treatment like surgery or surgery and radiotherapy, which will all depend upon the tumor stage. And there are targeted agents which are available to treat these days. For example, a lung cancer which is EGFR mutation positive can be treated with a suitable target. Similarly, tumors which are overexpressing HER2 can be treated with a targeted agent. So, therefore, these targeted agents are available for specific mutations and overexpression. However, they also have the property of developing this multiple drug resistance, the MDR. This MDR can lead to tumor relapse and poor prognosis. So therefore, after certain period of time, the targeted agents stop acting because of resistance which is being developed. At a late stage of a solid tumor, the tumor microenvironment is highly complex and it is highly heterogeneous. So initially, the genomic profiles of the tumor cells are preponderant for the modulation of the TME. As we all know, ECM is basically a 3D structured component which is comprising of collagen, elastin, fibronectin, hyaluronic acid, proteoglycans, and glycoproteins that support the tissues by encapsulating the cells and providing hydration and tumor homeostasis. So the whole thing is in a 3D environment, and now we will see how to target each of these components. Now, This is a tumor cell. So, with all the different components there, you have the lymphoid lineage cells, the tumor associated macrophages, the cancer associated fibroblasts, the mesenchymal stromal cells, the normal cells, and the tumor cells. Everything is present in the TME. Now, what are all the different ways in which this can be targeted? One could target the extracellular matrix. We can target the tumor cell derived exosomes. We can target the chronic inflammation or the tumorogenic factors which are supplied by the adaptive immune system. We can have targets which can avoid the neovascularization, we can target the endothelial cells or the pericytes, targeting the hypoxia and the acidosis which is associated, targeting the cancer associated fibroblasts, activating the anti-tumoral activity of an immune system is possible, and we can also inhibit the macrophages recruitment and differentiation. So the whole lot of these things are possible with drugs, and small molecule inhibitors is possible today, and that's exactly what we will be covering in today's lecture. The heterogeneity of tumor cells, the lack of tissue oxygenation, or increased inflammation in the TME can induce modifications in the ECM protein components, which can lead to increased ECM density and stiffness, and which is arising mainly from the increased amount of collagen deposition. So, this property is called as the desmoplasia, which is very common in a late stage tumor. Now, there are several studies, especially the one which we have highlighted here. This is a study which was done on multiple myeloma, which talks about a heparinase inhibitor called as the roniperstat, which was found to be effective in this multiple myeloma therapy. Now, the ECM composition plays important roles in tumor progression by providing tumor cells with sustaining proliferative signals, evading the growth suppressors, and resisting cell death, and enabling the replicative mortality, inducing angiogenesis, and promoting invasion and metastasis. So there are angiotensin receptor blockers, what we call as the ARBs. So there are several ARBs which are useful in treatment of hypertension and diabetic neuropathy, and studies have shown that there is a considerable preclinical evidence that ARBs can effectively reduce cancer progression, and particularly to gastric cancer. So there are ARBs like candesartan, losartan, olmesartan, valsartan. So these are some of the ARBs which are useful to treat hypertension, but they have shown some effect in the reduction of progression, especially for several cancers, but studies have been shown positive for gastric cancer. Now, ARB users in the study which was reported by Busby et al., I would request the listeners to kindly go through this publication. They have shown that ARB users had a moderately low risk of gastroesophageal cancer mortality than the non-users, with a hazard ratio of 0.83. Similarly, the ronespatat, which is a SST, which is otherwise called as the SST 0001. This is again another heparinase inhibitor which has completed a phase 1 clinical trial for the treatment of multiple myeloma. That is the reference which has been shown in the slide. So there is the clinical trial number is also given. I would request the listeners to kindly go through this particular clinical trial, where promising results have been shown in inhibiting the tumor growth when used alone as well as in combination with other TME targeting agents. Similarly, as we all know, a tumor microenvironment comprises of enzymes, the proteases, the degrading proteases called as the matrix metalloproteases. There are several drugs which are available which target these MMPs. Earlier, the MMPs, the pan MMP inhibitors, were found to be very toxic, whereas these days there are several small molecule inhibitors, MMP inhibitors, which have shown promise. Several drug targeting MMPs have been developed. For example, encyclinide, which is also known as the CMT3 or COL3, is an MMP inhibitor that has gone through several clinical trials for advanced carcinomas. The clinical trial numbers are shown in the slide for people to read and understand. So there are the structures of several small molecule inhibitors are shown in this slide. So the molecule A is called as the 10D, B is S17B, C is JNJ0966, D is NSC 405020, and E is doxycycline, G is minocycline, and H is ND336. So these are the structures of some of the small MMP inhibitors which are found to be clinically very promising. Now, after targeting the ECM using the ARBs and the heparinase inhibitors, let's move to targeting the hypoxia and acidosis. The figure here shows the oxygen level. The normoxia regions are from 45 mm to 35 mm. Now, hypoxia region is from 0.02 mm Hg to 35 mm Hg is the hypoxia region in a tissue section of 100 to 200 micrometers. Now, below 0.02 m will be the necrotic region. So, when the blood supply is limiting, when the tumor cells are rapidly proliferating, and when the blood supply is limiting, then within the tumor, these hypoxic regions are formed. These hypoxic areas create a very conducive atmosphere for expression of a protein called as the HIF1 alpha. HIF1 alpha is a molecular determinant that is upregulated as an adaptive response to alterations in the tissue oxygenation. So, whenever there is a shift in the tissue oxygenation, the HIF1 alpha and HIF1 beta can get expressed. The tumor hypoxia induces adaptive responses through enhancing unfolded protein response, that is UPR mediated upregulation of other proteins like ATF6XBP1 and ATF4, which in turn can inactivate the mTOR pathway. We will be seeing all this in little more detail in the subsequent slides. So, the severe and the functional abnormality of the tumor vasculature, an increase in the diffusion distances between the blood vessels leads to intratumoral hypoxia. So, this is the message that I want everybody to understand from this slide. Now, as I mentioned in the previous slide, in the hypoxia, that is, if you compare the tumor edge and the tumor core, in the tumor edge, the amount of oxygen availability is high compared to the tumor core. And that is why we say that the tumor core is hypoxic. Similarly, if you look at the acidic environment, the amount of proton ions will be more in the core compared to the edge. So, therefore, less amount of oxygen, more amount of acid leads to the hypoxic region. And then, so when there is a shift from the normoxia to hypoxia, there are a lot of metabolic reprogramming which happens within the cell. So there is this heat shock protein activation. There is a lot of endoplasmic reticulum related stress and GRP expression which is induced by hypoxia. There is HIF1 mediated transcription. Generation of cancer stem cell like cells are more in the hypoxic region. And then autophagy. There are altered signaling, secretion of exosomes, and altered epigenetic regulation and energy metabolism related reprogramming happens in the hypoxic region. Now, what happens in a normoxic situation? When the normal concentration of oxygen is maintained, then what happens is the HIF1 alpha protein gets hydroxylated. When the hydroxylation happens at position 402 or 564, what happens is there is another protein which is called as the von Hippel-Lindau protein, which can bind to this hydroxylated forms of HIF1 alpha. And this leads to ubiquitination of the HIF1 alpha protein and the protein gets degraded. Similarly, there can be a hydroxyl group getting added at the 803rd position, which will also alter the conformation of the HIF1 alpha in such a way that it will prevent its interaction with the P300 and CBP transcription factors. This is what happens in the normoxic situation, where this VHL protein is able to bind to the HIF1 alpha and degrade it. Now, what happens in the hypoxic situation? In the hypoxic situation, there is a lot of phosphorylation, deacetylation, and chaperoning by HSPs which happen, which lead to an excess of this HIF1 alpha and HIF1 beta production. And due to the chaperones, the heat shock proteins functioning as chaperones push this HIF1 alpha and beta protein into the nucleus. So here you see the HIF1 alpha and beta are entering into the nucleus. Now in the DNA, there is a region which is a HIF1 responsive element, HRE. Now, this responsive element area is bound by the HIF1 alpha and HIF1 beta, and this in turn is bound to the P300 family of proteins, and this complex, this ternary complex, can lead to excess target gene expression. Now, let us see what are the genes which get expressed in response to this HIF1 alpha and beta. So, you have several angiogenic factors, erythropoietin and its receptors, the glucose transporter regulators, that is the GLUT molecules, and all the enzymes which are necessary for glycolysis are expressed. And then all the regulators of autophagy, regulators of apoptosis and cell cycle, all the genes which are necessary for these pathways are produced by the HIF1 family of proteins. So therefore, when these signal transduction pathways are activated, these in turn can again lead to cascading effects of metabolic reprogramming, which happens through the Warburg effect. There can be autophagy with mitophagy, which can lead to resistance to apoptosis. So all these components, the cascading events, lead to radioresistance and chemoresistance. That is, any hypoxic area in the tumor will make the tumor resistant to any kind of therapy. Similarly, in a tumor environment, there can be a lot of changes pertaining to immunosuppression, pertaining to angiogenesis, pertaining to metastasis and treatment resistance. So let us understand how these things happen. Within the tumor microenvironment here, as I showed you, here there are the tumor cells. Now these are the new blood vessels. You have the macrophages, and then you have the tumor associated macrophages and the T cells interacting with the TAMs. So all these can lead to the immunosuppressive environment. So for an immunosuppressive environment to happen, you will have a decreased number of cytotoxic T lymphocytes, but there will be an increase in the T regulatory cells, an increase in the tumor associated macrophages, and decrease in the PMN leukocytes. So these kind of phenomenon will lead to an immunosuppression in the tumor microenvironment. Similarly, for angiogenesis, when you have increased number of blood vessels being formed, it could be because of increased amount of cytokines like increased IL-8 or increased VEGF, which are released by these tumor cells themselves, will lead to neovascularization, that is production of new blood vessels. So this will contribute to the angiogenesis. Now coming to metastasis, when you have excess MMPs in the extracellular matrix, now they can lead to degradation of the extracellular matrix, and also increased amount of hyaluronic acid can lead to metastasis within the TME. So these factors are important to promote the metastasis. And as I told you, due to the Warburg effect, and the glycolytic pathway getting converted from pyruvate to excess conversion of lactate will lead to an acidic environment within the tumor. That is the pH maintenance between 6 and 6.5. Now let us see how these promote to treatment resistance. So when you have decreased amount of ROS, decreased amount of HDAC, and then a lot of other changes which happen within the nucleus, which can alter the DNA repair mechanisms. That is, the cell's DNA repair capacity seems to go down, which can lead to more number of mutations. Therefore, the genomic instability within the tumor will also increase, leading to treatment resistance. Now, let us see how there is repression of oxidative phosphorylation which happens. Pyruvate dehydrogenase, PDH, it's a mitochondrial enzyme which is responsible for conversion of pyruvate to acetyl CoA. And this acetyl CoA will enter into the TCA cycle. Now, HIF1 alpha induces expression of the pyruvate dehydrogenase kinase 1. This is another enzyme. This gene, which encodes a kinase enzyme, which will phosphorylate and it will inactivate the pyruvate dehydrogenase enzyme. So, therefore, there is no production of acetyl CoA, and therefore this can repress the oxidative phosphorylation, and this in turn prevents the aerobic respiration. Increased production of lactate. So, this increased production of lactate in turn, along with overexpression of proteins like carbonic anhydrase 9 and carbonic anhydrase 12, are also regulated by HIF1 alpha directly, and therefore this also promotes acidification of the tumor microenvironment. The acidic environment decreases the proliferation of the polymorphonuclear leukocytes and CTL cells, the cytotoxic T lymphocytes, and it increases the recruitment of the TREX cells. Now, the secretion of cytokines and the chemokines will also attract monocytes, which will enable them to differentiate into macrophages, or this is what we call as the tumor associated macrophages. The tumor associated macrophages, or the TAMs, express a ligand receptor called as the PDL1 that inhibits the function of the T cells, that is, the cytotoxic function of the T cells is inhibited by the PDL1. We will be seeing the mechanism shortly. And the macrophages, the tumor associated macrophages, will induce inflammation. Now, these mechanisms are important to generate an immune suppressive environment in the tumor microenvironment. So, elevated lactate will also boost the interleukin 8 and VEGF to facilitate angiogenesis. So, we see that how much a pH change within the TME can disturb the homeostasis. The increased angiogenesis coupled with an acidic tumor microenvironment will lead to degradation of the extracellular matrix and expression of hyaluronic acid, which will support the tumor cell migration and metastasis. The lactate efflux will activate the metabolic substrates and also leads to transcription of genes which are involved in metabolic rewiring to influence the tumor's ability to respond to radiotherapy and the chemotherapy induced DNA damage. So, the points that we need to remember is that the activity of the HIF1 alpha, how it plays a role in acidification of the tumor microenvironment, and what happens as a consequence of this acidification, and how the immune atmosphere of the tumor microenvironment is suppressed, and what is the contribution of the elevated lactate towards angiogenesis, and what happens when there is an increased angiogenesis, and what happens when there is a lactate efflux, which in turn alters a transcription of lot of genes which are responsible for metabolic rewiring, promoting a tumor poor response and poor prognosis due to these environments within the TME. And how these can be targeted is what we are learning today. In this slide, what we are seeing are the GLUT transporters. They are glucose transporters. So there are several types of glucose transporters. They are called as the GLUT1, the GLUT3, and through which the glucose enters into the cytoplasm. And this is the normal glycolytic pathway that we have learned in our early classes. So glucose getting converted to glucose 6-phosphate in the presence of hexokinase, and from glucose to fructose, glucose 6-phosphate to Fructose 6 phosphate is due to an isomerase enzyme, and then there is another, the phosphofructokinase, another rate limiting step of glycolysis, which leads to another phosphoryl group being attached to the fructose 6 phosphate. It becomes fructose 1,6 bisphosphate, and this in turn splits that is one molecule of glyceraldehyde 3 phosphate and one molecule of dihydroxyacetone. So therefore, the subsequent steps of glycolysis leads to conversion to pyruvate, two molecules of pyruvate, and this then in the presence of lactate dehydrogenase becomes lactate. So therefore, the pyruvate to lactate conversion is mediated by this enzyme. In the case of a Tumour microenvironment, what we see here is the PDK1, which is formed as a result of HIF1 alpha, is inhibiting the pyruvate dehydrogenase step, and so therefore the pyruvate to acetyl CoA conversion does not happen, and therefore this leads to loss of the TCA cycle. The TCA cycle does not happen, and then along with that, the other players are the COX and then the other oncogene MYC, which is in turn can lead to transcription of several genes which are important in the process of oncogenesis. Now let us see how this HIF1 can be inhibited. Now thankfully there are a lot of HIF1 inhibitors which are available, and they have been very successfully used in several clinical trials. So first important HIF1 inhibitor is the topotecan. This topotecan is a topoisomerase 1 inhibitor, and this is an FDA approved inhibitor, and it has been shown to be useful as a second line treatment for ovarian and small cell lung cancer. Topotecan has been studied in a clinical trial for treatment of refractory advanced solid neoplasms expressing HIF1 alpha. So, in tumors which overexpress HIF1 alpha, topotecan has found to be useful. So, this is a clinical trial. So, one can go through this clinical trial website and identify and understand this trial. Now, basically, this topotecan is a synthetic derivative of the camptothecin, which can show the anti-tumor effect by inhibiting the topoisomerase enzyme. So there is a ternary complex which is formed by the topotecan and along with the topoisomerase enzyme and the DNA. So all three together form a ternary complex. This causes breakage of the DNA double strand, which is irreversible and eventually leads to cell death. So this is the mechanism by which topotecan acts. Evaluation of metformin. Metformin also has been very useful because it's an mTOR inhibitor, and this has been found useful in head and neck squamous cell carcinoma, and this is the clinical trial number shown here. There has been a phase 4 trial study which has studied the effect of everolimus. This is otherwise called as the RAD001 in patients with advanced renal cell carcinoma. So this is the clinical trial, and there has been a phase 2 study for the effect of everolimus, which is conjugated with lenvatinib. So both together, everolimus as well as lenvatinib together in renal cell carcinoma, and there has also been a phase 2 studies looking at the pharmacodynamics of digoxin along with HIF1 in a newly diagnosed operable breast cancer. So there are several trials which are going on with these HIF1 inhibitors in place. Everolimus is a derivative of rapamycin, which acts as a signal transduction inhibitor. Now, as I mentioned, this is an mTOR inhibitor. That is why, like metformin, everolimus also seems to work because it's an mTOR inhibitor. It targets mTOR, which is a key protein in regulating cell growth, proliferation, and survival. The mTOR activity is actually modulated by the phosphatidyl inositol 3 kinase, the PI3 protein and PI3 protein kinase and the AKT pathway. A pathway which is known to be deregulated in most of the human cancers. So this PI3 kinase, protein kinase B and AKT is a very important pathway, and therefore this is modulated by the mTOR. So the RAD-001, the trade name is called as the Afinitor. It has been investigated as an anti-cancer agent and based on its potential to act directly on the tumor cells, inhibiting the tumor cell growth and proliferation, and also indirectly by inhibiting the angiogenesis. So it is able to act both directly and indirectly. Directly, it inhibits the tumor cell growth and proliferation, and indirectly, it leads to reduced tumor vascularity, and this is the vascularity is decreasing because of the repression of the hypoxia inducible factor. That is, it represses the activity of HIF1 and the VEGF production and VEGF induced proliferation of the endothelial cells. So it is able to act directly this way. That way the RAD-001 has shown extensive promise. Now, this is the pathway. It shows how this everolimus, and there is also another derivative which is called as the temsirolimus. Both of them inhibit the mTOR. So, normally you have the tyrosine kinase receptor and the growth factor. So, normally when this growth factor binds to the growth factor receptor, this leads to the induction of the phosphatidyl inositol 3 kinase and the AKT pathway and the mTOR, and the downstream molecules are these S6K1 and the 4-EBP. These in turn can enter into the nucleus and modulate the gene expression, leading to proliferation, cell survival, and angiogenesis. And this everolimus is able to inhibit the mTOR at this pathway. So therefore, the pathway can get shut down at this point. Everolimus is approved by the FDA for the treatment of patients with advanced renal cell cancer after failure of the treatment with sunitinib or sorafenib. So, it is already FDA approved, and this is the structure of the everolimus. And everolimus binds to the FKB12, forming a complex that inhibits the mTOR kinase activity, and it reduces the downstream activity of the S6 ribosomal protein kinase 1 and the eukaryotic elongation factor 4E binding protein. That is, what is this 4-EBP? So, everolimus has been shown to inhibit tumor cell proliferation and angiogenesis, with the latter which is mediated by the inhibition of the hypoxia inducible factor 1 alpha expression. Now, after we have seen how HIF1 alpha can be targeted, let us see how we can target the acidic tumor microenvironment. As we saw, the microenvironmental acidity may differentially impact the diverse components of the tumor immune surveillance, eventually which can lead to tumor escape and cancer progression. So, the main important mechanism here is the tumor immune surveillance fails. The anti-tumor effectors like the T cells and the NK cells, they tend to lose their function. They undergo a state of a reversible energy, which is followed by apoptosis when exposed to a low pH environment. So, in a low pH environment, the T cells and the NK cells lose their function and they undergo apoptosis. The immunosuppressive components such as the myeloid cells and the regulatory T cells, which is the TREGs as we saw, are engaged by the tumor acidity to sustain the tumor growth while blocking the anti-tumor immune responses. Now, as I mentioned, there is a local acidity which will also influence the bioactivity and distribution of antibodies, and then whatever clinically we are, if we are giving an antibody or a drug, the local acidity will definitely influence its action, and this can potentially interfere with the clinical efficacy of the therapeutic antibodies, including the immune checkpoint inhibitors. So therefore, even if we try to target, if the local environment is not conducive pertaining to the pH, the activity of the agents may be lost. So therefore, tumor acidity is the central regulator of the cancer immunity that orchestrates both local as well as systemic immunosuppression that may offer a broad panel of therapeutic targets. So one has to modulate the tumor acidity to achieve maximum benefit. So one of the driving forces that renders the tumor microenvironment is a hostile milieu for the anti-tumor immune cells from hypoxia and cascade of biochemical reactions leading to local acidity. So this local acidity is actually creating a very hostile milieu for the anti-tumor immune cells. Now, how can we get rid of this acidification? The acidification of tumor microenvironment seems to protect the cells from chemotherapy due to an alteration of pH partitioning at the cell membrane, which results in an extracellular accumulation of the chemotherapeutic drugs. These drugs, due to the acidification, will not be able to enter into the cells via passive diffusion. So, how do we ensure an efficient drug delivery? To ensure an efficient drug delivery into a tumor cell in an acidic tumor microenvironment, there are several clinical trials which are proposing using combined therapies that can target both the carbonic anhydrase and the tumor cells, which includes the use of acetazolamide and radiotherapy for small cell lung cancer treatment. So, people have shown that the usage of acetazolamide along with radiotherapy has helped. So this is the clinical trial number, as well as use of SLC 0111 and gemcitabine. So the here the combination of SLC 0111 and gemcitabine can help in better availability of gemcitabine into the pancreatic ductal cells. So which is actually positive for carbonic anhydrase 9. So if a tissue is positive for carbonic anhydrase 9, the study shows that this combination of the two agents can help in effective tumor response. Similarly, combination of acetazolamide and temozolomide has been successful in malignant glioma of brain. So this is the detail of the clinical trial. So here the investigators have proposed to study the carbonic anhydrase inhibition. The acetazolamide functions as a carbonic anhydrase inhibitor, and that along with a concomitant radiochemotherapy in localized small cell cancer has been useful to has shown some progress, and it is in the phase 1. That is, the overexpression of carbonic anhydrase is important, and the anti-tumor effect of preclinical acetazolamide in various tumor lines, including neuroendocrine tumor lines, have been studied, and there is an observed synergy which people have observed between irradiation and inhibition of carbonic anhydrases, and the potential anti-tumor immune effect caused by the decreased extracellular acidity has been studied. This SLC 0111 is actually a substituted benzene sulfonamide small molecular inhibitor of carbonic anhydrase 9. Just like acetazolamide, this particular small molecular inhibitor also works against carbonic anhydrase 9. The objectives of the first in-human, that is phase 1 study, were to determine the safety and tolerability of this component, this particular small molecular inhibitor, in patients with advanced solid tumors, and to establish the recommended phase 2 dose for the future clinical investigation. So this phase 1 study shows that the SLC 0111 was safe in patients with previously treated advanced solid tumors, and the safety and the pharmacokinetic data supports 1000 milligram per day as the recommended phase 2 dosage for this particular small molecular inhibitor SLC 0111. So this will be able to take care of the carbonic anhydrase overexpression. Now, coming to the third aspect, avoiding the neovascularization and targeting the endothelial cells and the pericytes. Now, bevacizumab, Avastin, is a very, very famous molecule, and bevacizumab or Avastin is an antibody which targets the VEGF, and this was the first anti-angiogenic agent which was approved by FDA, that is already available in the clinic. The fluorescent form of Avastin, which is called as the bevacizumab di-E800CW, has been showing promising results for its use in tumor imaging. So bevacizumab along with this particular fluorescent dye has been useful in imaging of tumors. The tumor visualization with near infrared fluorescence, which is what is called as the NIRF imaging, might aid exploration and resection of the pancreatic cancer by visualizing the tumor in real time is possible if this particular agent is used along with bevacizumab. Conjugation of the near red infrared fluorophore, which is the IR dye 800CW, and this is conjugation of the near infrared fluorophore, that is the IR dye 800CW, along with the monoclonal antibody bevacizumab, results in enabling the targeting of the VEGF growth factor A, that is VEGF A. Now, if you see here, these figures show how the neovascularization takes place. The tumor itself is secreting the VEGF. This VEGF will increase the number of blood vessels expression, and therefore you see that new blood vessels are formed to support this particular tumor. Now, bevacizumab is able to bind to the VEGF. So, the VEGF which is secreted by the tumor is bound by bevacizumab, which in turn prevents the formation of new blood vessels. So, similarly, if you see here, you have the receptor, the VEGF-A binding to the receptor, which is leading to angiogenesis. Whereas the Avastin, the monoclonal antibody, otherwise called as bevacizumab, raised against the VEGF-A, binds to VEGF-A, and therefore it is not available to bind to this receptor, which is functioning in an anti-angiogenic fashion. Avastin specifically inhibits the VEGF extracellularly. Now, this particular table shows the VEGF and the VEGF-R, that is the growth factor as well as receptor targeting therapeutic agent, and the therapeutic strategy which was used and the cancers in which they were useful, and this is the clinical trial reference. So, I would urge the listeners to kindly go through these clinical trials. Now, coming to the first trial where bevacizumab has been used, and this is, as we saw, it is an anti-VEGF, and this has been used in a chemotherapeutic cocktail, that is bevacizumab along with 5-fluorouracil, folinic acid, and panitumumab, and intra-arterial versus intravenous oxaliplatin. So, this combination versus oxaliplatin has been studied in colorectal neoplasms. Similarly, cisplatin with etoposide versus cisplatin, etoposide, and bevacizumab. This combination has been studied in small cell lung cancer. Bevacizumab versus placebo in thyroid. Bevacizumab as a second line treatment in intrahepatic cholangiocarcinoma has been done. Bevacizumab along with another anti-VEGF antibody LY01008 with carboplatin and paclitaxel versus bevacizumab with carboplatin and paclitaxel. So, this or that. So, along with the combination of LY01008 and bevacizumab as such has been studied in non-small cell lung cancer. Then there is another study which has been done on ovarian cancer. Here it is along with the olaparib, which is a PARP inhibitor, along with the cediranib, which is a VEGF-A inhibitor, versus olaparib alone. And another molecule which is a ramucirumab, which is basically an anti-VEGF receptor, along with paclitaxel versus placebo with paclitaxel. So, this has been done in gastric adenocarcinoma. So, these clinical trials can be referred to understand the role of the anti-angiogenic reagents. Now, after targeting the angiogenesis, now let us see how one can target the immune system. Now, considering the role of the immune system in cancer, there are several routes that could be used to tackle the tumor progression. First one is inhibition of the macrophage recruitment into the tumors. We saw that the tumor associated macrophages get recruited. So, if we could stop the inhibition, if you could stop the macrophage recruitment, it would help. Then inhibition of the macrophage differentiation into pro-tumoral phenotypes, which is called as the tumor associated macrophages. So, this differentiation has to be stopped. And then targeting the chronic inflammation or the pro-tumorigenic factors which are supplied by adaptive immune cells. So one needs to target the inflammation. The fourth aspect is activating the anti-tumoral activity. We have to activate this particular aspect within a tumor to circumvent the risk of developing cancer or a poor prognosis of patient when a tumor is already established, and this is exactly what we are doing in immunotherapy. Overall, the macrophage targeting strategies show therapeutic efficacy. Nonetheless, when we use it in a combination along with the conventional cytoreductive therapy like radiation and surgery or chemotherapy, or along with an angiogenesis inhibitors, or immunotherapy, the better research results can be achieved. So overall, it has to be used in combination for better results. Additionally, the other strategies which involve targeting the macrophage recruiting mediators have been explored. For example, the chemokines, the complement components, the colony stimulating factor, VEGF. So these can also together be used. Now let us see, suppression of an anti-tumor immune response is, is one of the very main mechanisms by which the tumor cells escape destruction from the immune system. How does this happen? Now, there are this myeloid derived suppressor cells, what we call as the MDSCs. So, these are your MDSCs. They represent the main immune suppressive cells present in the tumor microenvironment that sustain cancer progression. So, these MDSCs basically are the main players which are present within the tumor. Now, these MDSCs are nothing but a group of immature myeloid cells with a potent activity against the T cell. So these MDSCs are basically myeloid cells, and they have a activity they act against the T cells. That is why you see they mainly inhibit the T cells. So this inhibition has to go. Although no therapeutic targets specifically target these MDSCs, they have been approved till date. So, as such, there are no drugs which can directly target these MDSCs. But we can use agents which can prevent their differentiation and inhibit their development, infiltration, or activity are being evaluated. So, the MDSC accumulation is mediated basically by two signals. Number one, there can be high levels of tumor derived growth factors. So you can have GM-CSF or MCSF, VEGF, all these, the growth factors which are released from the tumor themselves can promote expansion of these immature cells from the bone marrow and spleen, and they can inhibit their terminal differentiation into macrophages, dendritic cells, or granulocytes. So therefore, there is a inhibition in their terminal differentiation. Secondly, presence of the pro-inflammatory cytokines. So it is due to the tumor-derived growth factors as well as pro-inflammatory cytokines which are released from the tumor, like interferon gamma, IL beta, interleukin 4, interleukin 6, IL 13, TNF alpha. All these promote the pathological activation of these MDSCs. Now, if you see here in this cell, in this cartoon, now this is your MDSC here. So, if you can, there are agents which can promote this because they are in the de-differentiated state. They are kind of creating an immunosuppressive environment. So, if we have agents which can promote their differentiation, these MDSCs can get differentiated into macrophages and dendritic cells by using several agents like all trans-retinoic acid, vitamin D3, STAT3 inhibitors. These can promote differentiation of the MDSCs to macrophages and dendritic cells. Similarly, one could have methods to deplete this population. So that is done by chemotherapy using several agents like gemcitabine, 5-fluorouracil, paclitaxel, doxorubicin. All these chemotherapeutic drugs can bring down or deplete this population. There is also a way to block the recruitment of these MDCs. So, these MDSC recruitment into the tumor microenvironment can be blocked by several agents. So we have the CCL2 antibodies, we have CXCR2 inhibitors, CCR inhibitors, several other VEGF inhibitors, then you have the amino bisphosphonate. So there are several compounds which can inhibit or which can block the recruitment of the MDSCs into the tumor microenvironment. Similarly, you have other components. The same components can also be used to inhibit the MDSCs mediated immunosuppression. So basically, the T cells should be because these MDSCs tend to inhibit the T cells. This mechanism need to be worked into so that the T cells have to get activated. So there are several therapeutic agents that target the macrophages and the myeloid-derived suppressive cells recruitment in the intervention clinical trials. Now we'll see, now this is a trial, this particular molecule, that is the PLX 3397. This is basically a CSF1 receptor inhibitor. This particular compound, this agent has been found to be useful in advanced solid tumors, giant cell tumors, melanoma, pancreatic and colorectal cancer, gastrointestinal stromal tumor, advanced solid cancers, gastric cancers. A lot of trials are going on and in several stages. These are the phases of the clinical trial. So they are all in several phases of the clinical trial, which is exploring this particular therapeutic agent. Similarly, there are other types of CSF inhibitor which are there, which are in clinical trials for several advanced solid tumors. Similarly, you have the tyrosine kinase inhibitor Chuaruranib, which is useful, which is being studied in ovarian cancer, small cell lung cancer, hepatocellular carcinoma, and then you have this particular small molecule inhibitor which is being tried in pancreatic cancer and melanoma. And then you have another, if you see, there are so many different types of therapeutic agents which are basically targeting the CSF, that is colony stimulating factor 1 receptor. So after targeting the MDSCs, next we come to targeting the chronic inflammation. As we all know, any chronic inflammation is conducive to oncogenesis, conducive for a tumor formation. Inflammation is something that we always need to pay attention to. So we all know this non-steroidal anti-inflammatory drugs are widely used as antipyretics, analgesics, antiplatelet agents. So they are operating through the inhibition of the COX activity, which are your cyclooxygenases. So one such NSAID, which is called as the aspirin, has been identified as the broad spectrum chemopreventive agent based on the data from several clinical and epidemiological study. So if you see, these come under several categories. You have the statins, the metformin, the NSAIDs, and the anti-infection agents, and several natural supplements which are coming as nutraceuticals. All these are promoting the anti-inflammatory property in a TME. So all these are known to be having some effect in bringing down the inflammation. Inflammation, that is your berberin, selenium, and then you have the omega-3 fatty acids. So all these come as vitamin supplements, natural supplements, and then you have the NSAIDs in the form of COX-2 inhibitors that we take. And then you have the metformin, the statins. All these are in different study phases, but found to be useful in targeting chronic inflammation. Now, little bit about the mechanism of the cyclooxygenases, how these NSAIDs are able to act. So the cyclooxygenases, they are basically two types, the COX-1 and the COX-2. These are the major targets of the non-steroidal anti-inflammatory drugs. So normally the COX can activate the AKT, the mTOR, and the NF-kappa B to support cancer survival and proliferation either directly or via the production of prostaglandin E2. So the COX in turn promote the AKT or they can also lead to production of prostaglandin E2. This prostaglandin E2 will bind to the receptor which is called as the EP4. The prostaglandin E2, which is produced in a COX-2 dependent manner will bind to the prostaglandin E2 receptor EP4. So, if you see, this binds to the EP4 and it can induce intracellular signal transduction, whereas the COX-2 functions to downregulate the expression of DNA demethylase TET1. The EP4 signaling will upregulate the DNA cytosine methyltransferase 1. So, they function differently. The altered expression of both of these epigenetic regulators result in silencing the tumor suppressor genes, and this in turn can promote cancer initiation, which could be potentially prevented through treatment with a COX-2 inhibitor. And celecoxib, there are several trials. It's one of the well-known chemopreventive agent which is useful in bringing down the inflammation in the tumor environment. There are several clinical trials which are focusing on interleukin 1 receptor antagonists. So, therefore, there is a particular compound called as anakinra. This is called as the Kindred. This is an FDA approved IL-1 receptor antagonist. This is used in the second line treatment of rheumatoid arthritis, but it is also showing promising results in treatment of breast cancers along with bone metastasis. So, there are trials which are going on. Similarly, there is another molecule called as the canakinumab, which is basically an anti-IL-1 beta monoclonal antibody, which is also commonly used for treatment of inflammatory diseases, but it is showing promise in reduced incidence of lung cancer in a clinical trial. So, all these molecules which are showing promise as a anti-inflammatory agent is also showing promise as an anti-cancer agent.